record. Okay. And obviously, for those of you guys who are able to participate, maybe this is one of the first times you're participating, and especially for my residents here who this is a weird time for them to have rounds in the middle of the day, so they actually do get recorded. And from talking with our training director, if you're not able to call in at the time that you wanted to listen to them afterwards, that's fine too, and that kind of counts for attendance. And then for all of you guys who are clinicians who are calling in, or maybe just now learning that these things happen, we have an archive of some of the material. We sometimes forget to record them. If you want to ever kind of go back and listen to some of the material that we've discussed in the past, that's fine. Or if you ever want access to any of these cases after you've heard them be discussed, that's fine too. Just trying to make sure we've got a good number of people as we start. It seems like you guys can see the OSU logo and you can see the chat, or sorry, the participant number. Is that correct? And I just want to make sure that everybody can at least hear me. I'm talking on my cell phone. Is that okay? Is this volume okay with everybody?
It's working for me.
Okay. So, JD, would you like to start with the clinical history? I can pull up the submission form you had for Ranger, if that's what you want to start with?
Yeah, sure. That is totally fine. So Ranger is a 8-year-old, let me just make sure I'm not making that up, 8-year-old male neutered red bone hound. And he was referred over to our hospital for further evaluation. He had been seen the day before at his primary care hospital for hematochezia, vomiting, and when pressed, the owners report that he's actually been declining over the past 6 weeks, that his appetite was pretty picky. He's been losing weight. That seems to correlate during that time period, maybe a little bit longer than that as well too. When he was seen at the referring vet's office, they did some blood work to try to figure out why he's having a decreased appetite, intermittent vomiting, the hematochezia, and they found that he was quite azotemic, that his creatinine was 12.3, the BUN was greater than 120, the phosphorus was greater than 16, and mildly anemic with a hematocrit of 31%, normal white blood cell count. And so they sent him over to us for evaluation. So this was the case we saw in kind of late April. So we took him as a transfer and we did some additional diagnostics. We did an ultrasound and we found that bilaterally the renal parenchyma was pretty hyperechoic, and there was very minimal corticomedullary distinction that was really hard to figure out where was cortex, where was medulla. There was multiple anechoic foci throughout the entire cortices. And there was some renal pelvic dilation of about 4.5 to 5 millimeters, but there was no proximal ureteral dilation. And the overall appearance to his kidneys, our radiologist thought that it was consistent with severe bilateral chronic disease. The pyeloctasia could be a component of pyelonephritis or just secondary to diuresis and polyuria, but they didn't think it looked like a classic polycystic kidney disease case. All the cystic changes were pretty small within the parenchyma and just looked like really bad kind of small irregular kidneys. At our hospital, we repeated some lab work and found that his azotemia was probably more marked than what was initially thought. We had a creatinine of about 11 for him, and we did have a BUN that was up to 388. Now, I do think some of that was likely due to GI bleeding. I don't think that BUN was elevated just only due to the magnitude of azotemia. He was a bit muscle wasted, so certainly his creatinine could be underestimating the decrease in his GFR. I don't believe we have an SDMA on him. And he was minimally proteinuric. His UPC was 1.1, so certainly way more profound decreased GFR versus the amount of proteinuria that we're seeing. And on our urinalysis, we did not see any evidence of pyuria or bacteriuria. So I was really not that suspicious that he was going to have pyelonephritis as the cause, and I was more worried that he had end-stage disease. So we offered to treat him and likely doing dialysis to give him some time to see if he was going to recover, but my fear is that he was having chronic disease and he might not. And ultimately, when everything was put in front of the owners, they ended up deciding to euthanize him, to put him to sleep. And so they did not decide to go any further, but they were kind enough to let me harvest one of the kidneys and send it out so that we could try to get a little bit more information to figure out, can we put pieces of the puzzle together to try to understand what has been happening.
So, and I do, for the clinicians that are involved or are calling into this conversation, our part of our goal for this service obviously is diagnostics to impact patient treatment. So that's why it is run as a kidney biopsy service. But any of these cases in a scenario where you really just wanted to put more of the clinical data into some kind of integrated diagnostic final diagnosis for the owner, contact me, send me an email, tell me about the case, and most of I'm very happy to look at these tissues for you. Most of it is just making sure I have fresh tissue. I obviously don't want to look at an extremely autolyzed piece of tissue that's from an animal that's been dead for days and days and days before the autopsy, and a case in which you don't have any clinical data at all. Like, we didn't even know what the creatinine was. But like, if you have good clinical data and you have, you've been working with this patient for a while and you really wanted to figure out why things didn't respond, and maybe the owner couldn't afford a biopsy, maybe the animal wasn't stable enough for a biopsy. That's a lot of times where I get these autopsies in a bottle, perhaps, or these, just entire kidney specimens that are submitted to me. And then if you can grab urine at the same time, that's so useful. So oftentimes, you guys probably understand that with the kidney biopsy service, a lot of times what I'm evaluating are renal biopsy samples from dogs that have glomerular disease. So proteinuria is the big driver for the issue. So getting these samples from AKI dogs or CKD with really good clinical history and clinical data, that's just kind of rounding out our archive so we can learn more about all these types of diseases and not just proteinuric kidney disease. So just send me an email if there's something like, give me a few clues to the case, get me interested in, and then usually we can figure a way for the samples to be evaluated, either, depending on the situation, whether it's just the histology that's usually always all that's needed. We may not need electron microscopy. In this particular sample, I know that some people are calling in and maybe not necessarily able to see all of the images. It looks like, it looks like, I think hopefully everybody can at least see most of the images. You guys should be seeing an H&E slide. This is an autopsy case, so it's a big piece of tissue. And I think you can even see at this magnification, and even when we were trimming the specimen, we saw these enormous holes or circular structures that are the cysts that were identified on ultrasound. And some of them are quite large, and to the point where I can look at it on the slide, and it's at least probably 5 millimeters in diameter. And I'm not sure how big the biggest one was on ultrasound, JD. Does that sound about right?
I would say maybe up to 6 millimeters was maybe the largest one that we measured, but they were pretty diffuse, and many were quite smaller than that.
Yeah, so that's exactly, and it's always the difference between microscopy versus versus the gross specimen and the ultrasound. So I remember you saying something about the cysts weren't large enough to be really having peak polycystic kidney disease on your list, and I agree. These are microscopic cysts. They're cysts that would be very pinpoint holes when you were cutting the specimen from. If you were to say do an autopsy on this case, they would be like these little kind of pinpoint bubbly appearance. But then when you look at them on the slide, they look enormous. But if you were to look at them in the dog, polycystic kidney disease cysts are centimeters in diameter, not necessarily these smaller little millimeters in diameter. And then the next thing that kind of grabs my attention is the basophilic aggregates. So that's going to be a whole bunch of inflammation we're going to see here. These large aggregates, and sometimes I think you guys can hopefully see the hand that I am showing on the screen.
Yes.
Okay, good. So these kind of aggregates are oftentimes radiating, so they seem to be near at least starting maybe at the corticomedullary junction, sometimes maybe even being at the outer medulla, and going towards the renal cortex. So we've got a lot of inflammation in here as well. We have these enormous cysts. And then we have a lot of eosinophilic material, and this material is going to be collagen, so we're going to have a lot of scar tissue in these kidneys. And then you can occasionally see a few areas of renal parenchyma that looks like it could have been more normal. So you actually have profiles of ducts, and you have glomerular structures that look like they could be more normal. And I think some of the reasons this tissue gets a little fragmented is there's some mineral in here, and so oftentimes when the microtome knife is going through mineralized tissue, it kind of disrupts and drags because it cuts across the mineral and it drags that through the tissue. And for example, one thing that can be a little subtle that you kind of have to be on the lookout for is see how a lot of the tubular basement membranes are pulled across and apart from the tubule epithelial cells, and the basement membranes are a little basophilic. So this is kind of mineralization of the tubular basement membrane profiles, again, because of this end-stage really advanced kidney disease. Then if we're looking at the specimen for to try to figure out which compartment was maybe damaged first. And oftentimes that can give us a little bit of an idea of the etiopathogenesis if we know, oh, this was originally a glomerular disease and the tubular system got damaged secondarily, or vice versa. So sometimes, we have the benefit, or we have a good enough sample that we can identify that aspect. For this particular sample, all of the components seem to be scarred and have some degree of damage. So we have these things here, which are little tiny sclerotic glomeruli. And then this is a sclerotic glomerulus and a dilated Bowman's capsule. We have dilation of the tubular profile. So this is a very fresh specimen. I think it looks like on your submission form, JD, you said you did the postmortem pretty much soon after euthanasia. It says that the samples were in formalin within 20 minutes. So this kind of dilation let me move this participant thing out. This kind of dilation isn't secondary to autolysis. This isn't just the epithelial cells falling off the tubular basement membranes. These are actually pretty intact, they were viable at the time they were put in formalin, epithelial cells, and they have lost their brush border, and the lumen itself is dilated, probably because something is decreasing urine flow deeper in the renal parenchyma. And then the thing that happens is that for the people who are looking at these specimens and maybe aren't used to looking at a lot of kidney samples, they're going to come across glomeruli that look like this, and these glomeruli are large. and they have adhesions or attachments between the tuft and Bowman's capsule, usually at a couple of locations. Bowman's capsule itself is quite dilated. And the other thing is that they kind of look like they have too many blue spots in them. So they look like they have too many nuclei. And so for people with less experience, this kind of gets into being diagnosed accidentally as a proliferative or a membranoproliferative process. And that's actually incorrect. What's happening is there are too many cells. It is a hypercellular glomerulus, but the cellularity is almost always limited to the mesangial zones. And then the other thing is the glomerulus is enormous. And the capillary walls themselves actually look like they're fairly normal thickness. So to me, this is a glomerulus that got incredibly large because it had to. It was trying to compensate for the fact that there were probably too few nephrons functioning in this dog. And so we have compensatory hypertrophy. And when you have glomerulus getting really large, it often also gets too many cells within the mesangial zones. So it is a hypercellular glomerulus. To say it's mesangial-proliferative would be a fine diagnosis, but to say membranoproliferative would be incorrect because the hypercellularity is limited to the mesangium and the capillary walls look like they're within normal limits.
Rachel, for the novice pathologist, let me also point out that you're talking on the H&E, looking at the H&E about certain aspects that you're sort of mind's eye filling in that are actually better seen on PAS and I'm not complaining, but to really have a sense of where the cells are, look at the one stained with PAS and get be able to outline the basement membranes and things like that, and also the capillary wall thickness. So Rachel knows what she's seeing, even though she, it's sort of transposing the visual impressiveness of it from different stains. But to work it out in your own head, look at the different stains. That's how to learn it. Yeah.
So, George is completely right. And so I kind of started with the H&E, and the PAS is usually which one I prefer to look at when I'm trying to evaluate glomerular appearance. So the mesangial zones, we usually say the maximum number of nuclei you can have in those areas is 3. So we get occasionally where we get some 4 mesangial cell nuclei. We hope, and then we look at the capillary walls, and this is a 3 micron, actually very well cut capillary wall, and they actually look fairly normal. These are podocyte nuclei out here. We prefer the PAS because I think it's clear to see this is podocyte nucleus, this is podocyte cytoplasm, and then this is the glomerular capillary wall. You can see a distinction between that staining, and that's why this is a very helpful stain for us to assess capillary wall thickness and capillary wall architecture. And then the silver stain will also be very helpful. I think this one actually, we're having some timing issues when we're incubating our silver stains. Our silver stain, I think, got a little bit overstained in this particular case. But the PAS is quite nice to look at the capillary wall thickness. So I tell my residents every time they are looking at a kidney for a biopsy sample, or even when they're looking at a kidney from a board's perspective, that they need to give me an estimate of how many glomeruli are non-functional. So how many of them are globally sclerotic? And so here are 2 globally sclerotic. They're almost like literally only have 15 cells total in this glomerular tuft. And the PAS is a very easy way to pick up which ones are sclerotic glomeruli versus which ones are just little, if it was just fibrosis from collagen, from interstitial fibrosis, it would stain like this. But this is the type of way that base membrane collagen stains on the PAS. So I expect them for a biopsy perspective or from a forwards perspective to at least give me an estimate. Is it 10% of glomeruli that look like this? Is it 50%? Is it however many percent? In this particular case, when I did my count, 80% of the glomeruli looked like this. So if you guys who are clinicians realize I'm saying that 80% of the glomeruli are probably non-functional, then you already kind of know why this dog ended up being euthanized and was not necessarily able to improve even after additional treatment. So here, again, more globally sclerotic glomeruli, they just pop out with this stain. These globally sclerotic glomeruli that you might accidentally say, if you were looking at the H&E, they would blend in with the background interstitial collagen. These guys really pop out when you're using the PAS. And then again, here's another just enormous glomerulus. He had to get very large to compensate for the fact that there's a lot of nephron loss. So they get quite large. They get very abnormal. This one has an adhesion. So I know it looks like we have Purdue calling in, and we have my residents that are in another building, and they do not have access to a microphone. So they know what this lesion is. This is an adhesion between the glomerular tuft and Bowman's capsule, so that's the synechia. And I want them to type into the group chat what happens to result in a synechia formation, and they're going to type it in right now. And I'm going to move on to something else that's also interesting on the slide. So, hey, go for it, Maggie. I hope you're still here, Maggie. Did you have to step off? Let's see. Oh, there she is. Okay, Maggie's going to type. Podocyte loss. Yes, you're correct. So what happens is, if everybody can see that my residents got this correct. So there used to be a podocyte over here, and maybe even like 5 podocytes or whatever, and they died. So they fell off, they detached, they went out into the urine, and then you had basically naked glomerular basement membrane. It's kind of floating here in the middle of this free space, and then it bumps up against Bowman's capsule, and it decides to stick there. So that is the kind of stepwise process of how a synechia gets made. And I'm just going to do a little bit of a pathology nerding out for a moment to discuss what we talked about a couple of days ago at the Renal Path Atlas discussion. And it's going to be the concept that as these synechia form, this used to be a glomerulus, I promise. So as these synechia form, they make these weird stretching, they stretch the tuft. Here's another thing that used to be a glomerulus. So you can imagine there's probably a synechia here, there's probably a synechia here, et cetera. And so as this glomerulus becomes unable to let the urine exit the glomerular tuft and enter the proximal tubules, this thing gets very distended. And so that's why we have a lot of open Bowman space. And so we even talked a lot about how the proximal tubule, which might have been this for this guy, they actually can detach from the junction to Bowman's capsule. And so they lose this attachment, and then they become 2 isolated structures. What that means is that as this glomerulus continues to filter, it's still filtering blood. All the filtrate gets into Bowman's space, but now it can no longer leave into the proximal tubule. And so Bowman's space continues and continues and continues to dilate. And then where these adhesions usually had been, that's where, if you think about, it almost looks like a spider web at that point, where you have these really strong, firm adhesions between the tuft and Bowman's capsule, but Bowman's capsule is getting larger and larger, so it stretches out the glomerular tuft. And you can see these very, very atypical looking glomeruli with with these little, almost like little extensions all throughout Bowman's capsule. Were you going to add something to that, George?
No, well, I could say that, conceptually, there is the idea that the glomerular tubular junction is a delicate place, okay? There's, having looked at kidneys for a while, one gets an impression that there are changes that sort of begin at the tubular pole, if you will, of the glomerulus in many different situations, in periglomerular fibrosis and whatnot. And of course, the epithelial cells that are the tubular lining, proximal tubule lining, are contiguous with the epithelial cells just inside Bowman's capsule that are, if you will, the parietal epithelial cells of Bowman's capsule, and of course a different phenotype, but they've got to be close relatives where they are. And so there's just the idea that the glomerular tubular junction is maybe predisposed to damage in ways that the rest of the tubule isn't, at least in certain circumstances. And the other point is that in any, however it comes to pass, there is this concept of atubular glomeruli, and once the junction is damaged or becomes non-functional, you end up with trying to filter into a glomerulus or through a glomerulus into a closed chamber that is now Bowman's capsule without an outlet, and that may lead to some of the glomerular tubular, the cystic glomerular atrophy that characterizes the lesions oftentimes. And finally, going back to that hypertrophied glomerulus and, quote, the loss of podocytes, another concept is that the enlarging glomerulus, the ability of podocytes to replicate and become more numerous and spread themselves out over the, if you will, the increasing acreage of capillary wall outside may be limited, and you end up with potentially barren outside of capillary walls, glomerular basement membrane, and that if it comes to Bowman's capsule, sticks to it and forms a synechia. So it may not be necessarily absolutely loss of podocytes as it is podocyte failure to keep up with the hypertrophy.
Yep, exactly. The other kind of interesting thing about this case, is the concept of, and I hope you kind of saw as I was going through the other slides, just as we were kind of speaking about that, is that there are the large cortical changes, and they're quite impressive, and they get you, interested. You can see the cysts already. And then I always have to remind my residents that you just have to make sure the papilla is there when you're doing an autopsy specimen. And you really need to make sure you need to see if it's normal and if it was included in the section. So this one, we actually have pretty good papilla. We have urothelium that's lining it. It looks a little blunted, I'll be honest. And this is renal, pelvis, wall urothelium. And you can already see that the collecting ducts are also very dilated. So this whole distension and cystic change is actually full thickness. It's throughout the course of the nephron. It's not just Bowman's capsule. It's all segments of the nephron have some degree of dilation and distension. And so it's, there's plenty of different reasons why you might have only dilation of Bowman's capsule, but when you start to see that pretty much anytime you look at a segment of the nephron, there's at least an example of mild to maybe even moderate dilation. And so when I was doing my due diligence to check out to make sure papilla was represented in the slide, I was able to catch this little lesion. Now, we don't have the whole segment here on this particular wedge, and it very well could be that there's probably even better representations of what's going on in the paraffin block still. But we're looking here, this is collecting duct, probably like a medullary collecting duct going out towards the exit route. And you guys can see a lot of basophilic nuclei that are hanging out in the lumens of these collecting ducts. So to me, this suggests that in addition to having really bad cortical damage, having glomerular damage, having a lot of glomerulosclerosis, we also have evidence of inflammation within the ducts and within the renal papilla as well. And so when that happens, oh, I see that Dr. Nabity has also joined us, and Dr. Hokamp also just walked in at the exact same time. Creepy. So we have this debris. So these are actually a lot of times polymorphonuclear cells. I see the little lights pop up. So there's inflammatory cells, neutrophils that are coming in here. You guys can clearly see this. I just love this picture. You can clearly see that these polys are coming from the peritubular, periductular capillaries and deciding to cross the ductular basement membrane to get into the lumen. So this, by definition, is evidence that there is pyelonephritis. Now, I don't know if this was only pyelonephritis to begin with, or whether or not this was a damaged kidney that then was more was more sensitive and possibly got damaged by reflux. And the pyelonephritis is a secondary lesion. It's very possible, but there is at least still ongoing papillary damage. And there's the very bad damage in the cortex and throughout the renal parenchyma. I did not see bacteria in pyelonephritis even having the inflammatory cells here. We oftentimes might not be able to catch bacteria, or it could be that the inflammatory cells are actually just responding to a nauseous agent. So sometimes when urine gets refluxed back into the kidney and causes a little bit of leakage into the renal interstitium, you're going to have a lot of inflammation secondary to that too. So it may not necessarily be infectious pyelonephritis, but we at least meet the criteria of having inflammation in the renal papilla. And so that suggests that there was at least at some stage in this dog's life degree of pyelonephritis. I bottom lined this as a kind of nephropathy characterized by, which I know a lot of people hate that diagnosis. What did I call it, JD? Let me open up the report 1 second. We did not do immunofluorescence. We only had formalin fixed tissue, and we did not do EM on this. So I said nephrosclerosis with 80% global glomerulosclerosis. Nephrosclerosis just literally meaning the entire kidney is scarred. If I think that the vasculature is scary and also damaged to the same degree or to a similar degree, then I'll call it arterionephrosclerosis. But nephrosclerosis being that the entire kidney scars, we've got 80% global glomerulosclerosis, we have segmental glomerulosclerosis, we have cortical cyst, tubular degeneration, and then we have the pyelonephritis. And so it's hard because of the chronicity of this lesion to figure out which came first. I would favor that the tubular interstitial disease was primary. I don't know. I think I would favor that the tubular interstitial disease was primary because of the proteinuria being still so mild. Although our counter argument to that is that if it had been primary glomerular disease and then it was in an end stage, oftentimes the UPC decreases. George, do you have an opinion?
Well, the way to get a lot of protein in the urine is to have a lot of filtrate, and there's not a lot of filtrate, and there's very few filters left. So, but I share your view that this is probably more a primary tubular interstitial injury leading into obsolescence of lots and lots of glomeruli. Now, but and I would just throw in, saying pyelonephritis is absolutely accurate, but people translate that into bacterial pyelonephritis.
Yeah, exactly.
We're not really saying that necessarily. We're saying inflammation of the papilla and evidence of active tubulitis with migration of inflammatory cells through tubular walls. But the word itself doesn't imply any specific provocation that has made it so.
Yeah, I agree. And then JD did say that he did have to go answer a phone call really quick, so he had to step away. I don't know if any of the other clinicians wanted to speak up or have any specific questions about this case. And you know, it probably is not, it's probably more than to see the type of dogs that get kidney biopsies, which are, you know, non-enzymatic, nephrotic range proteinuria or subclinical proteinuria or whatever. So this is probably more typical of some of the patients that you would see. But I don't know if there's any other questions, or maybe even the clinical pathologists have questions. We did not get urine on this dog, unfortunately. So we didn't, and I don't know if JD was able to culture. I know his submission form said that there was no clinical indication to prove that there was a pyelonephritis in this dog. But that's the concept of, you know, just because we say that there's inflammation in the renal pelvis, renal papilla, we're not always saying that it has to be bacterial origin, or we're not saying the bacteria were there or are still there. They could have been here, they could have came and went, and now we're just seeing the residual effects.
And the other piece of this is, I'm not, JD's not here to tell us exactly, but this dog's been sick for a while, been seeing veterinarians for a while maybe, and that, I mean, it's hard. It's hard for a sick dog to go to a veterinarian without coming home with something, and usually an antibiotic. And so it may have some antibiotic on board in the 6 weeks or so that it's getting worse before it gets referred. And I'm not, you know, but it doesn't have to be active bacterial nephritis, pyelonephritis at this point, even if it at some point in what was colonized. On the other hand, you know, it's a male dog, and male dogs with bacterial urinary tract infections ascending to the kidneys is, you know, that's not a common thing. So.
Yeah. Okay, so we're kind of halfway through. I was hoping to at least get to show another interesting case. If that's okay, if JD wants to, if he has any more follow-up, we can ask him when he gets back. He just has to take a phone call. So unfortunately, with the second case, the clinician isn't here. It's not, it is another unfortunate autopsy situation. Let me get the folder up 1 second. I have a very detailed discussion for this case. Let's see, 1 second, George. It's the here it is. Okay. So this case is actually was a dog that was owned from by a veterinarian, and I'm gonna just, so this is kind of the history that we were given. It's a dog that lives in the West Coast, and so there was a lot of stuff going on with this dog. It is kind of the question of the clinical data doesn't always fit with what we're seeing on histology. So this dog had been previously healthy. He was, you know, 6.5-year-old lab retriever. He had always had kind of normal blood work, the high end of reference range for serum creatinine, and then he was able to concentrate his urine, and then he I think was probably in the history that doesn't seem to be on here is I think he did go kind of on vacation. Oh yeah, here it is. He'd been at the owner's rural property for about in the pond for a few days, but his leftover vaccines were up to date. And then after that, he developed acute onset of anorexia and vomiting. And so they brought him in, and he had azotemia, hyperphosphatemia, and proteinuria. He had some casts, and he had hypoalbuminemia. And so his screening test for lepto was negative at that time. He went for hospitalization, and I think eventually he got on to dialysis. He did have antibiotics, and his fluid rate kind of was difficult to, he basically was becoming edematous. So then he progresses, his azotemia gets worse. So from the fifth, which was the third, which was a serum creatinine of 2, and on the 7th, his creatinine's around 9. He gained about 10 pounds from fluid overload, and he had a lot of effusions. He had GI signs also as well. So then he decided to, they decided to proceed with dialysis, and he then became, had respiratory distress kind of after following his first treatment of dialysis. One of the kidneys went to a diagnostic lab in Washington. The other kidney came to me. I do not have electron microscopy and renal fluorescence. I've finalized this case, but I'm still trying to figure out what the etiologic agent might have been. So I will show you. I'm just going to show you the H&E first. Okay, so again, this is an autopsy specimen. They just kind of gave us slices of kidney. We do have kind of near the renal papilla, but not actually urothelium, so we didn't get all the entire renal papilla. We just have medulla. And I think you can see in comparison to our previous medulla, there's not inflammation in here. There are some protein casts, but there's not a lot of, there's actually no interstitial inflammation. So this isn't something that came up from the lower urinary tract into the renal pelvis and renal papilla. And then if we kind of look at the corticomedullary junction area, you see these foci of red. This is going to be a lot of interstitial hemorrhage that is a little pretty obvious. It's these little radiating streaks of interstitial hemorrhage. And then you can sometimes see where there's areas that are more superficial inflammation. And then some protein casts that are kind of popping out at this magnification as well. So looking at this is again this is an autopsy specimen, but it's a very well preserved autopsy specimen. I have very clear evidence of hypercellularity. Even on the H&E, it can kind of pop out, which we were able to pick out from the other case too. So hypercellularity, the other one, we were able to see it. But in this one, in these particular glomeruli, it's not just hypercellularity that's hanging out in the mesangial zones. I hope everybody can see, well, I'm sure you can because I'm going to point it out to you, that we have capillary lumens in here, and then you have these little like kind of lobulated nuclei. Those are a whole bunch of polymorphic nuclear cells, or probably neutrophils, that are in circulation within the capillary wall and these capillary lumens. And so these capillary lumens are inflamed. Look how thick they are, and we'll get to the PAS again to look at that. But the walls are thick, and those that activation of the inflammation system right then is recruiting a whole bunch of neutrophils into those capillary lumens. Now, what has happened here is that this part of the capillary is kind of exploding, and all of these are cells and matrix that are coming out into Bowman's space, and we have better examples as well. And they're not everything. So it's not every single glomerulus. It's just occasionally where you're going to see these little exploding areas and a little bit of fibrinoid tuft necrosis. Glomeruli are so damaged that they are rupturing and releasing their contents into Bowman's space. And so when we see that process, residents over in VMAB, you have glomeruli that are glomerular capillary loops that are exploding and releasing their material into Bowman's space. And what does that end up causing when you have inflammation coming in here into Bowman's space? I'm waiting for your answer, people over in
there it is.
There it is. Yay, good job. See, I'm so proud of my residents. Okay, so we have Crescent formation. JD, we moved on to the other case just in case you're curious. This isn't Ranger anymore. Sorry.
Oh, I figured. No problem.
I thought you would think this is interesting too, though. So we have polys that are in circulation. We have fragmented nuclear debris. We have capillary loops that are just chock full of material. We have crescents. We have very thick walls. And now I'm going to move to, do I want to move to the, I'm going to do one more thing really quick. 1 second. If we're looking at the vascular pole of these glomeruli, you can see, sorry, 1 second, I'm sorry. You can see that the vascular pole has fibrin and red cells that are coming out and exploding from the vascular pole. So we have evidence of damage at the base of the glomerular tuft as well. And so oftentimes we can see that that fibrinoid vascular necrosis in the glomerular tuft. We can see it in the afferent/efferent arterioles as well that are going to the glomerular tuft. And so that is another feature of this process. And then we have protein casts. Some of these are actually, so here's the difference between a protein cast, which is just a whole bunch of proteinaceous fluid. We have cellular casts, and just trust me, these used to be cells. You can see that little bit of granularity, so that's dying cell cytoplasm. I guess if you compared this material to this, that is the cytoplasm of the epithelial cells. So these are dead epithelial cells that are basically making these almost like coagulum that is getting removed out into the urine. Some of them are starting to mineralize. We have mineralization as well. So in addition to having glomerular injury, we have really bad tubular interstitial injury and tubular interstitial degeneration, necrosis, and mineralization. This isn't bacteria. This is just mineral. It's kind of variable in size, and some of it is quite dense, and some of it's quite loose. And so this used to be and they're all kind of admixed with this pink coagulum. So this used to be epithelial cells that have now degenerated and died through mineralization. And lastly, we have a little bit of interstitial inflammation. It's actually not as prominent nearly as the tubular interstitial degeneration necrosis. That's pretty extensive, whereas the inflammation is more limited in distribution. And then I'm going to show you the checker. So when I'm looking for crescents, so I'm looking at crescents. The diagnosis, if you have a lot of crescents, we often talk about being a crescentic glomerulonephritis. And crescents are, they're easy to see with the H&E. They kind of lose their impressiveness on the PAS because they often have, they just kind of look really pale on the PAS. They do look bright red on the trichrome because of all the fibrin. And so we'll find out a couple of them in here. So you can see all these orange areas here because that's fibrin. Where's the really pretty one? Here's the gorgeous one. All right, so we've got this whole area that's like ruptured, and all this is either fibrinoid tuft necrosis. Fibrinoid meaning it looks like fibrin, but it may not necessarily just be fibrin. And some of it probably is fibrin, and it's kind of exploding into Bowman space. The other kind of interesting thing that you can see on the trichrome is that it's something you have to see it. Hi, Mag, and I'm trying to get a pretty one to show you. So here's probably more of a crescent, and then you can see this bright red material, and you can see it right next to the blue of the glomerular base membrane. So those are probably, I think, large immune complexes. I don't have an EM for this case, but to me, the way it's almost looking like a wire loop or like a hyaline thrombus in a really bad immune complex disease. I think that's what that is. And again, I definitely need EM to do this. I've asked them to send me fluoraldehyde fixed tissue, which they have available, but they're not sure if they wanted to pay for the EM, given that it was an autopsy specimen, and they aren't sure of the initial cause for the disease. So in my perspective, this is a crescentic glomerulonephritis. I think it's proliferative. I think that there is the potential that a lot of this is being driven by immune complex deposition. I think that there is also really bad vascular pole injury with a lot of fibrinoid necrosis of the afferent/efferent arterioles. There's tubular degeneration, there's tubular necrosis. This could be the longest morphologic diagnosis you could possibly come up with if you wanted to. I don't think it's ascending inflammation or ascending pyelonephritis. I will show you some urinalysis pictures from this case that Dr. Hokamp took for me. Oh, the granulars, okay. The granulars, yeah. So we have they did send out, they did send urine. Granted, it was urine that they had taken, like, I think a few days before the dog died, and then it had sat in the fridge for a while. So it's very contaminated, full of bacteria and yeast. But there are still casts that were being preserved in the urine. So the ATN is pretty impressive. And the diagnosis that you're working with based on kind of the clinical history and based on the first impression from the pathologist in Washington is that this is leptospirosis. And I have made my opinion strong and loud that if this is leptospirosis, it's the weirdest reaction to leptospirosis I've ever seen in my entire life. And that this fits more with a crescentic glomerulonephritis. I asked about possibility of tick exposure. They never saw a tick on the dog, and it's in the upper West Coast, so they don't really see a lot of borreliosis. Doesn't mean it couldn't be anything else. They did do a 40X, that was negative. But it doesn't mean that this couldn't be an autoantigen that this thing is reacting to. And I did put on the ASVNU West listserv that question of, you know, is there somewhere where people see lepto that results in really bad glomerular disease? And it sounds like JD was the one person who responded about the possibility of having proteinuria in a lepto dog. Do you have any other thoughts, JD? I'm putting you on the spot, sorry. I'm not sure, maybe you had to leave again? Oh, yeah,
But,
and so, yeah, go
let
ahead.
me comment about it, okay? Rachel?
Yes, please.
All right. So, number one, and I welcome JD's opinion as well and would defer to it. But there was a time when I was a clinician and saw these cases, and I agree with the clinical bias is to leptospirosis, because if just across the board, acute nephritis in a dog, the differential diagnosis is leptospirosis, and then other. And it's so commonly or more likely to be lepto than anything else that people tend not to think of acute pyelonephritis or acute glomerulonephritis or an acute eosinophilic interstitial nephritis like a methicillin drug reaction or any of those other uncommon things, but they do occur. Yeah, okay, and so this probably is the exception that proves the rule, if you will. Now, it's a very bad glomerulonephritis, bad in the sense that it's acute and very destructive to capillary walls and this sort of thing. It doesn't necessarily imply any particular antigen. It doesn't necessarily imply any large antibodies or anything else. It's the intensity of the tissue damage, complement mediated and other tissue damage incited by the immune complex disease. And acute glomerulonephritis occurs. It's just not what we usually see in dogs. We usually see subacute to chronic glomerulonephritis, and people tend not to think of it. The second thing is, if you read through the clinical summary carefully, this dog had proteinuria and was still maintaining some urine concentration and was so predisposed to fluid retention that they just started IV fluids and the dog blew up, like a balloon, right? And that leads to me to mention glomerular tubular imbalance. When there's a really abrupt damage to the glomerulus, but some preservation of tubules, what happens to begin with is that the tubules, you don't get a diuresis when you give them fluid. You actually get fluid retention. The fluid retention in the distal nephron is happening as part of the disease. Hypoalbuminemia is partly delusional because they're not excreting the fluid, okay? And you exacerbate it by giving them IV fluids, which the distal nephron is saving, and the onset and severity of fluid overload and edema is all the worse for the presence of glomerular tubular imbalance in acute glomerulonephritis. And that leads, think of the swelling of this dog that they described, swelling of its face, swelling of its legs, fluid. What happens also is that the kidney swells, gets edema inside the capsule, okay? And that actually leads to ischemic nephropathy, where the pressure inside the capsule from the edema is at the expense of good blood flow. People who do dialysis for a living will talk about anuric dogs who are sent to them in fluid overload, and they do dialysis partly to remove toxic waste, but also with the settings on the dialysis machine to remove remove the fluid. And when they get the fluid overload off, all of a sudden you get an abrupt onset of a diuresis. And they attribute that to decompressing the kidney and getting blood flow and urine flow through it and whatnot. So part of this dog's acute tubular necrosis as a lesion at necropsy is potentially attributable to ischemic nephropathy superimposed on the glomerular disease during the period of fluid administration and fluid overload and things that go with that. And but there's the idea of and I just don't think that the leptospirosis is why this dog is sick, even if there's a leptospira in it somewhere. There is just not the degree of inflammation. Now, I have seen dogs with leptospirosis that had UPCs. One that survived had a UPC of 8 upon admission, and one that died had a UPC of 40. But what I think happens with at least some of them is that it's not glomerular really, and it's the UPCs of 8 and 40 are too big to be just tubular damage. But real bad leptospirosis is a very inflammatory interstitium and tubular damage. And what I think happens is the exudation into the interstitium with the proteins in the inflammatory reaction and the change in vascular permeability in the interstitium damage tubules. And what washes down is the proteins in the inflammatory material from the interstitium into the tubule and then wash down and gets that high UPC. And you'll see it when the leptospirosis causes inflammatory detritus to show up in the urine.
And do you also think part of the UPC could be decreased creatinine excretion with the acute disease as well?
Well, it's contributing, certainly.
Rachel, do you can you remind us, were there casts in the urine on the very first urinalysis that was performed before fluids were given?
Let me look. Yeah.
I put the clinical synopsis together, and I think I tried to include everything of even peripheral importance that was included. I don't think they mentioned it in what they told us.
It said, yeah, it said the next day there were moderate granular casts, but that was probably after fluid, oh no. Maybe not. Yeah, even before fluids, it sounds like there might have been granular casts.
Yep.
Or that there were granular casts probably before fluids.
Well, the glomerular damage is enough to be damaging tubules downstream. I think it just the fluid overload has the potential to make it worse and make the ATN in this kidney is impressive in its extent and severity.
Well, and I know we're wrapping up. We're getting close to 1. I did want to show everybody the worsening story. I didn't run this. This was run by on the kidney that was sent to Washington. I've talked to that pathologist. It's not the University of Washington. It's actually like a diagnostic lab that apparently does kidney biopsy. I don't know. In there. So she said they see lepto a lot, and she said that they found this, but she said you had to hunt for them, whereas when she sees her normal lepto cases, they're actually quite prominent and common. So she said, yeah, like she was like, well, I thought that the reason that there weren't as many organisms was because it had been on antibiotics. And then again, she saw the inflammatory cells and glomerular capillaries. She didn't really give that much weight to that. And I kind of walked her through why this was truly a Crescentic GN. And so the steps now for this, as we wrap up these set of rounds, and I'll keep you updated, is that they sent off tissue to Washington State Diagnostic Laboratory, who is going to do PCR on the tissue and immunohistochemistry on the tissue as well. to see if there really truly were leptoorganisms in the specimens. And like I said, the lepto titers that they had run on this dog, they never really got convalescent titers because this dog progressed so rapidly, but the lepto titers that they did get were kind of in the, well, the dog had been vaccinated range, so it was the borderline. It wasn't, you know, super, super high lepto titers. So the serologies don't really give us enough things to hang our hat on. And then lastly, just because I want to promote that my residents are super smart, they made the comment about thrombotic microangiopathy, and you're completely right, Maggie. That's exactly what's going on here as far as the vascular pole injury, and I don't know if this is the glomerulus that has it, but when you have really bad endothelial damage, you'll have that fibrinoid necrosis of the vascular pole. And so we have that as kind of being the lesion that would be endothelial damage, whether it's glomerular endothelial damage or arteriolar endothelial damage. We can put that diagnosis of TMA. I chose not to use it in this particular case. I'm really hoping we can get EM on this dog eventually. And so I really want to know I'm just hoping that the endothelial cells will be gorgeous on EM, and I can see that loss of fenestration and that endothelial damage, then to truly say that there was a TMA superimposed on an immune complex disease. I've not seen TMA be this hypercellular in dogs. Let me say, I've not seen standalone TMA without immune complexes be this hypercellular. So because I'm still waiting and hoping that they're going to decide to call me back and say, yeah, let's go and do the EM, I kind of want to get that perspective before I put that tag on it. But it is 1:02. I actually have another meeting that started 2 minutes ago. So if you guys don't mind if I sign off, I think this is a good turnout. I'm happy that people came in.
Thank you, Rachel.
Yeah, thanks, guys. We'll send out another invite for next month. Thanks, guys.
Thanks.
Bye.